Bladder diverticuli can also cause pain, and that's due to they can have urinary stasis, which goes to become infected and become painful. Usually what you see on ultrasound are round, well-defined, fluid-filled masses, which can vary in size and disappear when the patient voids. In this case, on your right, a magnified view shows nicely the pedicle between the diverticuli and the bladder wall. Bladder tumors, which are more common in men than women, but women can present with bladder tumors, can present also with pain. And here's a case, a transabdominal study on your top left shows a polypoid mass protruding into the bladder. And on transvaginal, you see the wall, even better, the mass outlined by the bladder, the urine. And here on color flow, lots of flow seen centrally and low resistant waveform on color flow. And this was a bladder tumor in a postmenopausal woman who presented with bleeding. A premenopausal woman, this is not, the images are not very nice, but I love this case. And this is a bladder, transabdominal bladder, and we saw that in the base of the bladder there was this mass, the very smooth mass protruding into the bladder. And this was endometriosis in a premenopausal woman. Another patient with endometriosis that I had recently and we follow, this is the bladder, the wall is thin, it should be 2 millimeters, and then all of a sudden you see focal thickening in the wall of the bladder. The wall, this is a transvaginal study too, wall of the bladder. And this was endometriosis. Another patient, bladder, and these two echogenic, curvilinear echogenic structure was shadowing within the bladder. Here's the uterus and here's the bladder. Transvaginal study showed these curvilinear echogenic. These were bladder calculi. Patient presented with pain. Patients can present with abnormalities in the urethra that can cause pain, and they can be due to calculi, cysts, diverticuli, or stenosis. Also, calculi in the ureter can cause pain. So it's very important when you finish a transvaginal ultrasound and you're pulling out the transvaginal probe to look at the urethra. Many times we will find the cause for the patient's symptoms. Here we can see this was a transperineal study, and you see the curved line shows you the vagina. Anterior to the vagina, you see the bladder and the urethra. Within the urethra, there's a curvilinear structure, and this was a calculi within the urethra. Another patient, transperineal study. This is the vagina, this is the urethra, a cyst within the urethra. Bladder is here, anterior. Urethral diverticuli result from abscess formation in the periurethral ducts, which can become congested, obstructed, infected, and can also cause pain. And here's a patient in the urethra, the wall of the urethra. She had the cystic structure with increased flow. You see lots of flow within the surrounding, the periphery of the cystic structure. And this was also an urethra diverticuli that was infected. Transabdominal study shows a little echogenic structure right next to the wall with shadowing. We did transvaginal, and we saw a dilated urethra, and the calcifications or calculi were able to be identified. A different patient, transvaginal ultrasound showed a dilated ureter, and then in the distal ureter, the wall was very thick, and increased flow was seen within the wall of the distal ureter. You could see lots of flow. We did not see a stone in this case. This patient was treated with antibiotics and came back 10 days later, and the distal ureter was back to normal size. We feel that maybe she passed a stone, and this was inflammation of the distal ureter due to the recent passage of a calculus. Abnormalities in the bowel can also present as with pelvic pain. Masses in the bowel, for example, carcinoma, polyps, abscesses, diverticular appendiceal abscesses, dilated loops of bowel due to obstruction, or wall thickening of the bowel due to inflammatory or metastatic disease. Here on your left, normal distended loops of bowel. On your right, thickened wall of this loop of bowel secondary to ulcerative colitis. This was picked up on a transvaginal ultrasound. Another case picked up on ultrasound was distended loops of bowel. When we did a transvaginal study, we saw that there was a mass in the pelvis. We inserted water into the rectum, and we saw that the water delineated the mass, which was within the wall of the sigmoid. This was a sigmoid tumor, which was diagnosed on the transvaginal study, but because we had seen distended loops of bowel. This is in the right lower quadrant. It's hard to see, but you see a tubular structure, thickened wall, and then you see next to it a round mass, heterogeneous in appearance, and this is the appendiceal abscess, right where the patient was having pain, right lower quadrant. These are two transvaginal studies, longitudinal and transverse. Another patient with an appendicolith, and you can see here the appendix wall is very thickened, and within the appendicolith you can see this, the appendicolith is seen as an echogenic foci, and here thickened wall and an abscess adjacent to it. These are two transvaginal studies. Another patient presented with pelvic pain, huge, large, complex mass, echogenic fluid surrounding it. This was a large ruptured appendiceal abscess. Two other patients. This is another patient. You can see thickened wall. This was in the left lower quadrant, very thick bowel. The wall of the bowel is very thickened, and then you see this big heterogeneous mass adjacent to one of the walls. This was a diverticular abscess. Another patient, sort of ill-defined mass in the left lower quadrant. You see these echogenic structures within it. This is gas, and this was a diverticular abscess, which unless you look for it carefully, it can be easily missed. You can see that the wall is diffusely thickened of this loop of bowel, and this was metastatic disease to the loop of bowel. This is another patient presented with, you see a loop of bowel, looks normal until all of a sudden you come to one point, there's some thickening, focal thickening of this loop of bowel. This is in longitudinal, and this is the transverse views of the loop of bowel, a hypoechoic mass, seen anterior wall. When you ask the patient, she gives you a history that she recently had a polypectomy. So this most likely, we thought, was a hematoma secondary to the recent polypectomy. The patient was brought back a couple weeks later, and this was no longer visualized. Pelvic varices, which are dilated, incompetent ovarian veins, may also cause pelvic pain, and it's not sure why. It's thought that it may be due to venous stasis, which produces congestion and pain. Treatment for pelvic congestion syndrome include hormonal ovarian suppression, psychotherapy, oophorectomy, ligation of ovarian veins, and embolization of ovarian veins. And here we can see a transvaginal study showing the uterus and this tubular structure. This is a normal vessel seen in the adnexa. These are abnormal vessels. These are varices. You can see the uterus, adjacent to the uterus, there's all these cystic structures. When you put flow, they're all vessels. These are veins, dilated veins. They're abnormal, and they're pelvic varices, which can also cause pain. Another patient presented with pelvic pain, and when we did color, we saw that this iliac vessel had a clot in it. This patient also had an adnexal mass, and she had pelvic thrombophlebitis. Another patient with pelvic pain had a thrombus within the pelvic vein, and she had also deep vein thrombosis of her lower extremity, which extended into the pelvic veins. Also, pain can be due to abnormalities in the lymph nodes in the pelvis, either due to inflammation, metastatic disease, or lymphoma, as you can see in this case, an enlarged pelvic lymph node secondary to lymphoma. Also, pelvic pain can be due to structures such as a pelvic kidney. Here, this patient did not know she had a pelvic kidney on this transvaginal study. Another patient had a transplanted kidney, which was hydronephrotic, causing pain. In conclusion, evaluation of pelvic pain should be initiated with a pelvic ultrasound, transabdominal and transvaginal, to exclude gynecological and certain non-gynecological pathology. Most women with a normal pelvic ultrasound will improve with or without surgical intervention, and further imaging is unlikely to yield positive results. However, if the ultrasound is limited, MRI or CT of the pelvis may be helpful.